Hello, my name is Colton Rieger, and this is my benchmark assignment for corrective exercise. Thank you so much for watching. The impairment that I was given was an asymmetric weight shift to the right during the overhead squat assessment, as seen in this picture. The region of impairment that we're going to be looking at is the lumbopelvic hip complex. You go down, and then doing a systematic analysis on someone that has an asymmetric shift to the right, we see a muscle that is shortened, and that is the shortened or overactive, and that is the tensor fasciolata or TFL, and that is a hip abductor, but also a hip flexor. And you can see that in the first picture, highlighted in green. For our underactive muscle, we're going to be looking at the glute medius, and that is also a hip abductor, but also a lateral rotator of the femur. It was quite interesting looking at the potential causes for these two muscles. Since they're both on the same side, it's interesting that they both are abductors, but one is overactive and one is underactive. But once looking into it, it kind of makes more sense. First, a tight TFL is often associated with a bunch of sitting, and that's because the hips are in a flexed position, and it's a hip flexor, so that's going to become shortened or overactive. It's compromised for a weak glute medius, which is what we also see as being weak in our evaluation, or things such as repetitive motion, such as running, jumping, or hopping. And then for our weak muscle, we have the glute medius, and that's also caused by excessive sitting, or reciprocally inhibited from tight hip flexors, causing the glute medius to shut down, and that's where we'll get tight hamstrings that are overactive for the compromised hip extender. And what's really interesting is that these can cause a secular motion where we don't really know which causes what. Does the tight hip flexors cause the weak glute medius, or does the weak glute medius cause the tight hip flexors? And this could be a cycle where one is causing the other to become worse. And so that is promising for our interventions, because if we can decrease the tone of the tight muscle, then that'll improve the activity of the underactive one, and vice versa. For our inhibitory technique, we're going to be doing self-myofascial release of the right TFL with a lacrosse ball. The way you do this is you're going to want to roll until you find a tender spot on your specific muscle and hold it for 30 to 90 seconds. And you're going to do this daily unless specified otherwise. We're going to do this because the right TFL was shown to be overactive or short in our assessment during the overhead squat. So you're going to want to put it right where the TFL is. What this is going to do, it's going to decrease trigger point activity and also stimulate the autonomic nervous system. Contraindications would be hypertensive people or people with muscle imbalances, muscle strains to that specific muscle, such as the TFL. For our lengthening technique, we're going to be doing a standing static stretch for the right TFL. This is to decrease the muscle spindle activity that may be causing it to become shortened, and for reconcurrent inhibition to decrease the activity of that muscle. So what you're going to want to do is, it's about a split squat stance, but we're not going to squat. Basically, we want to get this hip into extension because the TFL is a flexor. We get in the opposite range. And then we're going to adduct the hip and cause a stretch across. And we're going to hold this for 20 to 30 seconds, or 60 seconds for older populations. Some contraindications are geriatric populations might not be able to sustain it, also some hypertensive patients or people with strains to that specific muscle. For our activation technique, we're going to be doing isolated strength. This is a movement that is supposed to increase intramuscular coordination and force production of a supposedly underactive muscle. We're going to be doing standing hip abductions because our glute medius was supposed to be weak on the side of the impairment. And this is done 3 to 5 days a week. You do it in 1 to 2 sets, 10 to 15 reps, and we're going to follow a tempo of a 4-second eccentric with a 2-second hold at end range. So I'm going to perform a few of those for you. Possible contraindications for this movement are things such as hypertension, muscle strain, or positional. If a mother is pregnant, we're not going to have them lie on their stomach prone. and things similar to that. For my integration move, I'm going to be doing lateral tube walking. The importance of this is that it also increases intermuscular coordination. It's a low force, high rep movement in proper posture, and is to teach the glute medius, since those are supposed to be underactive in our impairment, to work synergistically with the other hip abductors. You're going to want to do this 1 to 3 days a week, 1 to 3 sets, and you're going to, for reps, you're going to do 10 to 15, and the tempo is just slow and controlled, not necessarily holding and coming back. So I'm going to do 10 of those for you real quick. Some possible contraindications for those are muscle strains, hypertension, and also positionally for those who cannot be in that spot, do that movement with safe posture. Thank you so much.